All right, good morning, everybody, or good afternoon at this point. So I will ask for everybody's indulgence and patience. I know we have several folks that are coming from meetings that were ending at noon, so we may have folks who are coming in. If there are not seats on the aisle, if you can scooch over to minimize lots of noise for folks who are joining us already in progress, that would be wonderful. So I will say welcome to our colleagues at the Health Science Campus, our colleagues at Fox Chase Cancer Center, our Board of Visitor members, our alumni board, and to everybody who's here with us in person. We are super excited to be able to host somebody who can really speak to a lot of the values that we have here within the college. You know, focusing at, you're going to hear a lot about interprofessional education, what is and what isn't. And so I think our guest speaker today really will provoke a lot of thinking for you. If folks have questions, for those of you who are in the webinar, you can add those into the chat. We will take those questions at the end. And for everybody who's here in person, we'll save about 10 minutes or so at the end to have an interactive opportunity for dialogue with our guest speaker. So I will, it's my pleasure to introduce, and I do have to say, it's really nice. This is the first time that we're back in person for our Dean Seminar. We have been doing them virtual. We will continue to do them in this format where folks can be live in person, and we will still have the availability via webinar for our colleagues who can't be here, and particularly to ensure that all of our online students have an opportunity to participate. So without further ado, I would like to welcome our guest speaker, Rear Admiral Aisha K. She comes to us, and I think one of the things that's sort of unique, we were having this discussion last night at dinner. We talk about a lot of different opportunities in public health, things that you can be doing. And typically, we have not had somebody who is coming from the federal government. We have not had somebody coming in uniform. And so this will be a new experience for everyone. So Dr. Mix was commissioned in the U.S. Public Health Service in 2006 as a public health analyst at the Health Resources and Services Administration. Something that's really wonderful for us within academia, her focus at that point was really looking to mobilize the nursing community to increase awareness and the need for nursing workforce diversity, and working on designing strategies to increase retention and graduation, sound familiar, for our nursing students with a particular focus on diversity and bringing more students in from disadvantaged backgrounds. Rear Admiral Mix became the Chief Nursing Officer in October of 2019. And in that capacity, she had the honor to be advising the Office of the Surgeon General and the U.S. Department of Health and Human Services, thinking about things such as recruitment, assignment, deployment, retention, and career development for nurse professionals, and intersecting public health and nurse professionals. And at that point, she was providing leadership for over 4,500 commissioned officers and civilian nurses. Currently, the Rear Admiral serves as the Senior Health Policy Administrator. So we talk about wearing lots of different hats. She's got the clinical hat, she's got the administrator, the policy, but the Senior Health Policy Administrator for the U.S. Department of Homeland Security, Immigration, and Customs Enforcement Health Service Corps. In this position, she manages a team that's focused on the enhancement of healthcare delivery within approximately 240 immigrant and Homeland Security healthcare facilities. She's previously served as a senior policy analyst with the Office of the Assistant Secretary for Preparedness and Response, a liaison for emergency operations, translating disaster policy into practice, and ensuring the federal response to disasters and public health emergencies integrated behavioral health and address the needs of at-risk individuals and families. She's leveraged her knowledge and expertise in the nursing workforce development to design and implement expanded nurse deployment roles in instances of disasters, including case management, discharge, planning, patient movement, human services, and disaster recovery operations. And we heard a little bit about this last night, and I'm sure folks will have questions. It is pretty amazing, some of the experiences the Rear Admiral has had, and is very humble and is very gracious when she speaks about this. She was deployed to Monrovia and one of the first responders in 2014 to deal with the Ebola epidemic that was happening there. She has been on the ground as a first responder, whether it was Hurricane Irene, Irma, Maria. She led the field operations and the policy lead in developing long-term strategic plans for federal recovery opportunities in the U.S. Virgin Islands. So really has just seen it all and is going to share some of that with us today. The Rear Admiral graduated with her BSN and MSN from Hampton University, a Master's of Public Health from Johns Hopkins University. We won't hold it against you. And a DMP with a focus on educational leadership from Case Western University. So please join me in warmly welcoming the Rear Admiral.
Good afternoon. Okay, I know maybe you've had lunch, but we'll try again. Good afternoon. Got it. So thank you so much for such a warm and welcome introduction. Thank you for the opportunity to join you today, especially with this being the first back in person Dean Seminar Series. I will say that it always brings me just a tremendous level of excitement and joy to be on college campuses, because for me, it refuels my spirit to be in connection with students, with faculty, with administrators, because you all represent what's to come for us. And I'm beyond excited just to really see what you all will be able to do. So as was mentioned, I am Admiral Aisha K, serving as the Chief Nurse and also as an Assistant Surgeon General with the United States Public Health Service. I do, of course, bring you greetings. Click once, click twice, hit an arrow, push a mouse, space bar. There we go. All right, let's try this again. So, as always, I'm always going to start out and bring you greetings on behalf of our Surgeon General, Vice Admiral Vivek Murthy. So he does serve as our 21st Surgeon General, and in this capacity, he has become our nation's doctor, right? So if you consider all of us in the country living in a community, and we have a community doctor, he is it. And so as Surgeon General, what he stands to do is to really identify what the health priorities are for the nation. And so the 4 that you see listed on the slide are what he has identified for his term as our priorities. COVID-19 is no surprise, right? We're not out of the pandemic, so clearly that's important. Health misinformation, understanding how to address folks who might not have all the details, but you're really trying to get them on the right path. Health worker burnout, I don't have to tell anyone in here twice that that is a significant issue. That is one that is near and dear to my heart as well as his. And then, of course, youth mental health, which again, I'm sure I don't have to tell any of you twice, the impact that not only the pandemic, but all the things that we were facing before the pandemic continue to have on the youth across our country. So for me, though, as the Public Health Service, let me start by asking, how many of you have actually ever heard the Public Health Service before you heard that I was coming today? Thank you, I like it. So I'm always excited when I start to see more hands, because we are still one of the best kept secrets, right? So as one of the 8 uniformed services in this country, we are the only uniformed service whose sole purpose and priority is the public health of the nation, right? So what we represent is a cadre of nearly 6,000 officers who are public health professionals, and you'll see in the next slide where we span across different disciplines, but we serve in what we call our day-to-day jobs, right? So as you've heard, I lead policy within ICE Health Service Corps, but we also have the responsibility to deploy following disasters and public health emergencies, because those same skills that we utilize in our various organizations across the federal government are leveraged in times of disasters and when communities are in most need. So when you look at who we actually are, there we are. We have 11 different categories. One's highlighted, imagine why, right? Not that I'm biased or anything, but we do have 11 professional categories. Nursing is one. We used to be the largest category. We have fallen second as of last year, which I am certain is a direct result of our responsibilities during the pandemic. If you look at that list, if you could guess, which one do you think became number 1? I heard pharmacists, I heard something else. Health services, therapists. So pharmacists actually is correct. There are about 100 more pharmacists than nurses in the public health service right now. Nursing is sitting at about 1,200 of our nearly 6,000. So we're still a force to be reckoned with. Within our health services category are what most people know as our allied health professions, right? So we have our social workers, our MPHers, we have podiatrists, we have optometrists, we have a host of disciplines. Collectively, what we represent is this full force that creates our national public health department, if you will. And so what this allows us to do is to respond in a variety of capacities, again, as it relates to public safety, public emergencies, disasters, and also leverage that same level of expertise across the federal family where we all serve. So as the chief nurse of the nurse category, I, along with my 10 other colleagues, have the responsibility for advising the Surgeon General, advising the Secretary of the Department of Health and Human Services on what nurses and our respective categories can do. So when the Surgeon General identifies a priority, it is my responsibility to be sure to communicate how nursing can help forward that, how nursing can help engage, and what nurses need in order to be successful. So as CNO, I've created my top 3 priorities, which of course promote nursing as a profession, because we are always at the table and we should always be invited to the table, in which case when we're not, we create our own and invite others, right? Mobilizing nurses to address Surgeon General priorities. I'm one person. I don't know everything and I can't do it all. And so it's not only the nurses in the public health service, but nurses across the nation as well. And recruiting and retaining public health nurses. And this is key because it's very important to understand the need for a public health nurse specialty in addition to the other variety of specialties that we see across the nursing profession. My priorities also feed into what are some of the larger public health challenges that we all know, right? When I came into this position, little did I know that in less than 6 months, we would be smack dab in the middle of a COVID pandemic. So these priorities and public health challenges were identified even before COVID was on the scene. So you can imagine what this looked like for my term as I, grappled with what I intended to do in a world that I thought I knew, and then walk squarely into this world that all of us have known to love, right? So access to care, workforce diversity, community preparedness, and ultimately, how do we address these health disparities that we see by engaging and intervening where we see inequities? So that becomes my role kind of in framing the conversation that we'll have today, because one of the things that I'm most proud of is that I get to walk in this space that combines my passion of nursing and public health. And to the end, and the end is what I'm talking about when I say removing barriers for people, for families, for communities in their ability to achieve their highest levels of health and wellness. And so that really frames, where we'll go today in the rest of the conversation and the time that we have together. So let's talk about this thing called public health, right? So clearly it's not a new phenomenon for any of you because we're sitting squarely in the College of Public Health. But I want you to take this journey with me to really understand where we have come from and where we need to be at this point. Right? So there was a time in public health, and we reference it as Public Health 1.0, where we were really first understanding these different, knowledge points, these tools that would help us understand how to pull together medicine and public health in a way that really honors them both, right? The problem with that is we still kept it pretty much siloed. And so as a result, what we saw was then the same unequal access to public health services as we did to medical services previously. So we said, okay, we've got to do something different. We've got to really provide more structure and coordination to understand how to implement public health across this country. So enter Public Health 2.0. And at that point, what we realized is that we have these entities, these public health agencies, governmental agencies, who actually can coordinate this. And these will be the people who are responsible for getting it done, right? So we're going to partner, we're going to collaborate, and we're going to work together to solve all the problems of the world. And it made sense, it did, except that it limited public health engagement to only those who were within the established governmental public health agencies. And all of you, I'm sure, are well aware that public health happens even outside of what we traditionally consider our health departments, whether that be state, local, regional, or otherwise, right? So right around the time and creeping into the pandemic, we moved into this Public Health 3.0. And I can tell you, I was on a similar stage about 5 years ago, giving a presentation about Public Health 3.0 and how we can all be active in Public Health 3.0. And I still believe it, because what Public Health 3.0 did was bring in this understanding that within public health, we need what's called a chief health strategist. And a chief health strategist is that person who can have that 20,000, 30,000 foot level across a community to understand what it needs and understand who all needs to come together to address those identified needs, right? Because otherwise it becomes this thing that's everybody's problem and no one's problem at the same time. So no one's, tapped or accountable for addressing it, but we all can agree there is a problem, right? So enter the concept of a chief health strategist, which is someone who actually has that responsibility to coordinate all of these efforts to drive public health change, right? And so what this also does is it brings in the voice of the community. So this is when the discussion of social determinants of health, for example, became more apparent and really in our faces to understand the root causes of what's going on across our country. So a chief health strategist, social determinants of health that really tell you why people are doing the things that they do, how this came to be. Again, we thought that we were really doing a good job, and then COVID, right? COVID happened, and at the same time that we saw COVID, what we also saw was an increase in racial violence. And those two public health crises came together at a time when this country was most vulnerable. And so what we realized that even stopping with awareness of social determinants wasn't good enough. It's not good enough to know that you have a problem and then just sit around and agree that we all have a problem and live our lives. What COVID actually brought to the forefront were the continued disparities and inequities that we see across the nation. And it forced us to understand how that could be. Because in a time when no one wanted to get COVID, so clearly we couldn't use the same argument, well, they're smoking, so well, they must want lung cancer. No one wanted COVID, but yet we were getting it. And so the differences in information, for example, and I can tell you across the Black community, where there was a belief that Black people could not get COVID early in the pandemic. How do you ask? How could that be, you ask? Well, it's because the messaging and who we were seeing on TV did not look like us. So therefore, we must not be getting it. What was in fact happening is that we were getting it, but we were dying. So the inequity in the availability of services, the early diagnosis, the ability to put resources in communities that were most vulnerable were the gaps that we saw. And so we realized that we actually have to move past it. So Public Health 4.0 has become some of the new conversation lately. And what Public Health 4.0 adds is this lens that has the responsibility and the accountability to address and incorporate racial justice, right? To understand how that as a public health issue needs to be addressed in a systemic way, right? Not just, we play nice in the sandbox, but really how does that influence your policy, your programs, all of these things, that I'll go into a little bit more depth in a little while, but I want you to understand this evolution of public health so that you can also be a part of this thing called Public Health 4.0, because I can tell you it's not yet fully defined. And it's really still open to the conversation of what's important and what we need to focus on and how we need to do it. And I dare say with the workforce that we have coming on board and those that are new into the workforce are bringing this sense of, I need to support my well-being and I am just as important as the work that you want me here to do. We've got to be mindful of that. And we have to recognize what that means by way of maintaining a workforce who actually is willing, capable, and continues to have the same passion that we've had for it for a number of years. So just to kind of put this back in a nutshell, when we talk about, again, advancing public health 3.0 and beyond, it really is a conversation of how can you center the community in everything that you do. It's this conversation that I say all the time, nothing about us without us. You can't sit, and I can't sit in DC in my, federal building and determine what's needed in North Philly. It doesn't happen. I'd be wrong. And even if I spoke to someone, I can't direct what's needed in a community that I'm not a part of. It requires understanding, engagement, and participation of that community. What we're also talking about here is a transition from a focus on clinical prevention to one that really looks at, evidence-based. It also looks at a population level to understand how things came to be and what we see right in front of us, right? It's also looking at alternative settings and how we can work together to achieve health and wellness. Many people have heard me say, many of us are born in hospitals. We don't live in hospitals. So if the fundamental foundation for the basis of our care and treatment is based on acute care systems, what is the story that we're saying to the people in this nation? That we're all sick and from time to time you might get healthy. What if we flipped that on its head and came with an approach that actually respected and expected a level of health and wellness, and then we were prepared when things went wrong, right? So again, a shift. And it's not to say that, you know, we all must work in one space. No, it's to say that we need equal focus on the entire continuum and the entire spectrum. And then lastly, targeting the inequities in order to improve disparities. We recognize what the disparities are. I don't know that we need any more time to understand what they are, right? Now it's time to move towards why they are and how we can be in action to make a difference, right? Listening to those who are most impacted to understand their experience with it. Because if we as the providers are not hearing from the patients or the families or the communities, we still don't actually know what's going on. So this is the approach that I'm talking about when I say center community in order to advance public health. And if you'll understand, it actually takes all of us. None of us can do this in a vacuum. There's not one profession, there's not one discipline that can actually do this without the help of someone else. So this one is a favorite of mine because what it really does is it centers this concept of public health, right? And again, public health is not owned by anyone, right? We all can be and are a part of public health. And so what this particular slide is annotating is that there is a coordinating body, a coordinating person in some cases where you just don't have enough people, that is responsible as the public health agency. At the global level, that's the World Health Organization. At the national level, that's the Department of Health and Human Services. And then we have specific public health agencies, whether it's at a territory level, a tribal level, county level, city level, et cetera. But if you look at this slide, you recognize that public health touches everything. It touches everywhere that people are. And so when you look at your programs, you look at your initiative, you look at your partnerships, I would venture to guess that every one of you can see yourself in one of these colored dots on the slide. And what that means is anytime you are engaging in an effort that is supposed to be to support a community, if one of these dots is missing, I challenge you to go find the person, the people, the organization that represent it, because you're missing a part of the story. And what really this is really saying is that it will take a whole community approach in order to continue to move forward in public health, in order to move forward, especially post-COVID-19 pandemic, in a way that actually puts us all in action and not reaction. You guys with me so far? Got it, I like head nods. So I mentioned these social determinants of health. I don't believe that the concept is new to anyone. One of the things that I always talk about, especially, you know, as it relates to the work that I do with nurses, is sometimes people hear a term and they feel like they have to go back to school and learn all about it. Social determinants are not new. When I came through my nursing program, I learned that we look at people from a biological, psychological, social, cultural, and spiritual lens. That's social determinants. What it basically is saying is that you're looking at the whole person. And so when you're talking about social determinants, you're also looking at the whole community. So walking this through, we talk about what health is, right? And so what we have in place by way of prevention, treatment, care management, whether it's there or not there, right? Building a pretty building that has a multitude of services means nothing if people can't access it. You just have a pretty building, right? You haven't addressed access to healthcare. So then you move around, environmental, right? The environment within which people live makes a difference for their ability to achieve and maintain health and wellness, right? Because if you come to me and what I prescribe for you or what I recommend for you is daily exercise, but I'm actually afraid to step outside my front door, how then am I supposed to adhere? And now I'm in danger of being your non-compliant patient, but you never actually asked me what was in the way, because there could have been an exercise program I could do in the safety of my home or in my workplace if I had one, or if I don't have a home somewhere else. So those are the nuances that are important to understand, right? The social and community context. those who are actually experiencing racism, discrimination, and violence, right? In these instances, I also like to point to the K through 12 group, primarily the K through 5 group, because you recognize that they come from homes in a diverse set of circumstances, and we bring them into the schoolhouse and we say, sit down, be quiet, and listen until we tell you to go home. I don't know about any of your households, but I didn't raise my kids like that. So when they get to school, this is the first time that someone says that. And if you're not able to do it, automatically you receive the label that follows you through 12th grade. How do we identify and address the real lived experiences that people have at home in order to honor and respect them and incorporate them into how we engage? So let's change that, right? So students that are coming on campus to Temple University, everyone's coming from a different place and space and background, family circumstances, situations. I don't shed who I am to walk in the door and sit in a classroom. I bring my whole self. And if I didn't eat last night, or my kids ate, but I couldn't eat because we didn't have enough for me to eat, or if it actually took me 3 hours to get here because I had to take 2 buses and then a train in order to get here, and you're mad because I walked in 7 minutes late, you've got to be kidding me. So again, I say we have to understand these social determinants, because there are also social determinants that affect education in the same way that they affect health. So coming back around that same picture up here, so economic stability and what that means as it relates to social determinants of health. Again, another example is the COVID pandemic, where we saw that those who were most at risk were those who couldn't afford to sit at home and do their work. Not all of us have jobs where we can actually do it from the comfort and safety of our home with social distancing and isolation, right? My very extroverted college student came home and I couldn't socially isolate from her if I tried, right? Like, she wanted to play family games every night, and I am an introvert. Most people don't believe it, but I am 99% ISTJ. And she wanted to be up under me all day. And I'm like, public health, social isolation, we need space. But, you know, I say that in a lighthearted way, but understand that for many people, there was no choice to stay home. They didn't have the argument with their child who came home from school because they had to go to work and they had to put themselves in danger and indirectly then put their families back in danger when they came back home. So understanding the ramifications and the decisions that people have to make, which are a direct result of the circumstances within which they find themselves through no fault of their own, is important when we talk about how we can engage to address health equity. And then lastly, educational access and quality. This is also where I often talk about, especially in an academic setting, this notion of, you know, what is privilege? Privilege is the fact that you all are sitting here or online listening to me. Privilege is being able to hear a presentation such as this and have the time to set aside, to have access to Temple University, to gain an education, to have access to serve as faculty administration. That's privilege. And so what does that mean for you and those you come into contact with as you share your experiences, which then gives them an element of privilege, right? So what does that mean, and how can we even the playing field when it comes time for youth who are coming through or people who are interested in changing careers and have never had the benefit of this conversation? So I challenge you to train the trainer, if you will, and to take at least some aspect of what you hear today and commit to elevating the conversation, the piece that resonates with you. Because it's an important conversation, and I dare say if we start here with an understanding of social determinants and what makes people do, believe, speak, say the things that they do, we'll find that we actually have a better chance of engaging in partnership in order to support them on this journey of health and wellness. So this particular slide I really love because, you know, it's my simple way of, you know, incorporating social determinants, right? Simple. It's as simple as it is to actually do it, right? But I like this slide because what it does is it really pulls together a lot of what you all are engaged in within the College of Public Health and across the campuses of Temple University. So social determinants of health exist in and of themselves. We just talked about that. And then there are the health factors, because I do have people that are saying, well, Admiral Mix, there are some people who just will not do right, even if you gave them all the choices. You're right. Next question, right? You're absolutely right. People do have the ability to make the decisions that they deem best for themselves. What I ask of you is to not allow anyone to make an uninformed decision. Be the person that's available and open to providing the correct information, and then allowing the person to make the decision that they feel is best for them. And that is the best thing that you can do for someone else. So some of these health factors, right? So health behaviors and conditions, what you choose to do, how you choose to live your life, all of those good things. Mental health is an important piece, because you may have 100% physical health, but also be suffering from a mental illness or mental disability. That will absolutely impact your behaviors, impact your ability to achieve, complete health and wellness. And we have to be sensitive to understand what's in the way in those circumstances as well. Then the health factor of accessing the services, as I said, the pretty buildings that we build and hope that people will come. We've got to turn that on its head and actually bring the services to where people are. Imagine that, right? There was a time where we actually went into communities and understood the communities and worked with the communities to provide the solutions. We have to figure out what that looks like now in this world, right? What does it look like to bring the service to those who need it most? Because I always say, if you focus your actions, your energies on those who are most vulnerable, the entire community will benefit, right? So figure out who you're not seeing and figure out how you can get seen by them, not how they can be seen. No, how you can get seen by them, and you fought half of your battle. The reason why this is important is because the combination of these social determinants plus the health factors actually drive these population health outcomes that we keep saying that we're trying to address. But if we start all the way on the right side and we're just constantly talking about quality of life and morbidity and mortality and life expectancy, and we've got to do something about it, if we ignore everything that went into it, we will go through public health 1.0, 2.0, 3.0, and I dare say 4.0 and still be talking about it, right? My daughters tell me, don't talk about it, be about it. Same concept, right? We've talked enough. We probably agree. Now, what are we going to do about it? And how can we be in action? The top box references the fact that, as the federal government, as policymakers, we also have a responsibility in this as well, right? As the federal government, we are not in a position to dictate what any state or community does. We can inform, we can advise, we can fund, right? But ultimately, it's the decision of that particular state or, geographic location that has the responsibility for the folks. But it's also a responsibility that we have of understanding cultures and norms in a way that allows us to present options and initiatives and programs and funding in a way that does not box anyone in and allows for the unique translation based on the needs of the individual community and community members that you serve. And so that's an important thing too, because I think many times people are waiting for the federal government to give direction. That's not the business that we're in. We can give guidance, but ultimately it's not our call. And so we rely on each of you to figure out how to translate what we've said. I call it kind of the guardrails, and you all have flexibility within those guardrails, also called laws, right? But between those guardrails to develop the policies and programs that make sense for you. And so all together, that's how we actually incorporate social determinants in what we call upstream thinking. Anyone heard of upstream thinking before? Good, because I have a slide. So if all of you raised your hand, then it would have been difficult to go through the slide, right? So upstream thinking. So I know that you can't read everything on this slide, and that's okay. But what this slide actually represents is how social determinants kind of inform this scenario. So let me walk through it for you. So let's start with the bottom. So downstream, what you see is a situation where you've got a lot of people downstream. People are swimming in the water. Some folks are drowning. They're continuously being saved. Like we've got divers jumping in the water, saving people's lives, pulling out as many as they can. Some of the stronger swimmers are actually making it themselves, saving themselves, but we lose a lot of people. right? At some point, someone says, oh my goodness, why are the people drowning in the water? We've got to do something. So we move upstream. And so what we then do is we make sure that we've got swim lessons, because if you can be a stronger swimmer, chances are downstream, you'll have a better chance at survival, right? And so what that does is it takes some of the burden off of the divers and the rescuers downstream, because there are less people who are in danger, right? So that represents what we call our human services, right? So that's our life-sustaining kind of wraparound support systems that we put in place, right? When we're saving people, that's more like our acute care systems and our hospital settings, and the urgent and emergent care that we absolutely need. Once you add in those classes, because we've got to be stronger, if only you could be stronger, right? We're going to give them some free meals, because if you've got energy, then surely you can swim stronger and perhaps have a better chance. So we're going to give you the food, we're going to give you the classes, and everything that you need to be a better person. At some point, someone, likely one of you from the College of Public Health, will say, what are the people doing in the water in the first place? We're worried about saving them. We're worried about giving them lessons, but did anyone stop to ask people, why are you jumping in the water if you can't swim? Are they tripping and falling? Are they being pushed? How are they ending up in the water to begin with? And what is it that we need to do way upstream to avoid these issues and the burden on resources that we see downstream? That's upstream thinking. So when we apply it to the healthcare system and the health system in this country, we have to ask that question. When we're talking about things like the nursing shortage in hospital and acute care situations, yeah, absolutely. We can continue training nurses. We can continue training, RNs, LPNs, every variety of nurse, so that we can have as many nurses doing as many nurse things as possible. Why are our beds full? Why are people coming in such critical states? What are we doing before they get there? What are we doing in our communities where they live? What's going on that actually puts them in this dire circumstance that then creates a strain on our systems, right? Nursing and otherwise. Nursing is just one example. So again, I say public health has not only the ability, but the knowledge, the wherewithal, the connections, the collaboration, the partnership to really ask those questions at the highest level and actually have the time and space, right? Because while the other folks are saving people, while the other folks are putting together courses and all these support services that are needed, in public health, we actually have that time to sit back and look at the data, to look at the trends, and to understand, got it. So this is what we're seeing over here, and this is what we need to put in place. And sometimes that's a program, and sometimes that's a policy, right? Because programs tend to be voluntary, policies not so much. And so sometimes it's a combination of the two, sometimes it's one or the other. But that's what upstream thinking means. It means to really start and keep peeling back the layer, as I call it, being the eternal 2-year-old that keeps asking why. And for me, I tend to stop and slow down when someone says, well, it's the law. Okay, you've got me there. But if you land on it's the policy, even that can be changed, because if it's not working, it's time to have another conversation about it to see if the intended outcome is actually what you expected to see in the first place. So that's upstream thinking. So in a nutshell, right, and coming to kind of the close before we have some opportunity for dialogue, what's important to note is that, again, we cannot do this alone. And that's the collective universal we, right? The partnerships that I talked about at the beginning are extremely important. The collaboration, the interdisciplinary approaches, a lot of that actually begins in the academic setting, where you're actually having the opportunity to understand who the next person is and what they bring to the table. For me, I actually didn't learn, and I've talked to some folks earlier about, I didn't learn about other professions and disciplines and what they bring to the table until I was in my Master of Public Health program. It was then that I realized that the way that I would address childhood obesity was quite different than the way that the attorney who was in the course would address it, quite different from the physician who was in the course would address it. And I had an opportunity to understand and acknowledge what I brought to the table uniquely as a nurse, but also to understand where there was overlap and opportunity for someone to help me even do my job better. And so I offer that, across the college, across the campuses even, where are those points where you can come together on particular issues facing either the surrounding communities or the communities that these students represent, so that it's meaningful and engaging, especially for students. Because again, without students, none of us would be here, right? So it's important to continue that. It's important to understand where you are employing your upstream, your midstream, and your downstream approaches. And again, I say, because I don't want anyone to walk away thinking that the only thing you need are upstream. No, that's not exactly what I'm saying. It takes a combination of all three. What I'm pushing for is an equal focus, because right now we are hyper-focused on downstream. We're tapping a little bit on midstream, and there's a few of us who are engaged in trying to wave our hands way upstream. But open the doors for more of us to come upstream so that we can really get to root causes in order to see a difference, as opposed to blaming those who are finding themselves downstream. And, there's always the question of why is this important? So you heard mention of some of the work that I've done, especially as it relates to disasters, public health emergencies, deployments even. And what we strive to do, and with the Public Health Service, with our mission to really provide the care to underserved populations, but also to protect, promote, and advance the health and safety of the nation, the ultimate goal is to have resilient communities. I don't know about you, but I don't have a crystal ball. I don't know what's next, right? But I do know that in the past 5 years, we've seen multiple Category 5 hurricanes, we've seen wildfires, we've seen floods, we've seen a pandemic. I don't know what's next. Something's next. I don't know what it is. But how do we make sure that our communities are as prepared as they can be, right? And what that means is being as healthy as they can be. And so through everything I've talked about, it comes down to, again, the 2-year-old why. I hold myself accountable to that too, because somebody in here is saying, well, what does this matter? Well, my answer for you, right, is this. We have a responsibility because we are part of these communities. We don't operate in vacuums just because we're in academia. We actually go home and we are a part of communities. So when we talk about a resilient community, it is creating an opportunity for that community to be strong enough to withstand and endure and move through these devastating circumstances that we know will actually occur. So when we look at what's needed for that, it's the self-sufficiency, right? If you have to wait and depend on others to come and save you, you will be at a deficit. That time that it takes is important. And an example of this that I use, you heard mention of my deployment to the United States Virgin Islands. When a disaster hits, for example, Texas, resources can come from other states quite easily. You see many people clogging the highways, trying to drive in and volunteer and support. When a disaster hits an island, you don't have that same opportunity. And so if you haven't built in a level of self-sufficiency in order to at least sustain for that immediate period, that's critical. So how do you ensure, based on that particular circumstance, that that community is self-sufficient, at least for a period of time that you know that it's going to take to even repair a runway for a plane to land, right? Because that became some of the conversation. It wasn't that we didn't have people to go. Where are you going to land in a devastated airport? So the next is a conversation about engagement. Social isolation is a problem right now. It was a necessity for a little bit, but we're now seeing what the sequelae of that are. We're seeing how that's impacted people. And so now when we talk about community engagement, what that means is actually an awareness of what's going on with your neighbor across the street, down the street, around the corner, so that when something happens, go to check on Miss Mix down the street. I know that she's electric dependent. We lost power. Has anyone checked to make sure she's okay? Things like that are what community engagement means. It means that the community is identified, the community is engaged and informed, and also gets to share what the needs and concerns and issues are, so that when someone descends, because of the federal government, unfortunately, that's what we do. We descend and come to help, but we rely on our community gatekeepers to let us know what to do from there. Coming around to education, That one's a big one because I think many times when we talk about preparedness, we talk about individual preparedness and what will you do at your home or in your institution if something happened to your home or your institution. As we broaden that conversation to community preparedness, it's the education and understanding of what that means for a community to be prepared. What is your role and responsibility as a community to be prepared? How do you address access and functional needs in the community in a collaborative way so that when you say something like evacuate, it means the same thing to everyone. And you don't have a subset who might have mobility challenges and can't get on the school bus that you sent, right? Or you have someone who is not willing to leave their pet, literally come hell or high water. What does that mean? Or I'm afraid to leave my house because I stand to lose more if I leave because it'll be vandalized than if I stay. So these are conversations that are very real conversations, very real lived experiences that occur. And how do you get ready for that? What do you have in place because you know that that can happen? What will you do differently? And then lastly, it comes back to the partnerships, which is where I started the conversation. This notion of interdisciplinary versus multidisciplinary. Multidisciplinary means that we are all seated in this room and we're going to take this information and go back to the group that we already belong to and continue to have the conversation in our group. So as a nurse, I'm going to go back and talk to nurses about what I learned today. That's actually not effective. Not effective in a sense of a collaboratory approach to really enhance partnerships. What we instead need is to walk into a room and to bring information, understanding, and an open mind so that you walk out with something different than what you brought in, built on the collaboration and engagement of others, right? What you also need is coordinated engagement. Chaos is not good. It's not fun, it's not good, it's stressful. So a coordinated level of engagement. Again, community-centered. My hope is that I've said that on every slide so that you at least don't forget that part. And then lastly, this kind of conversation about what is life-saving versus life-sustaining. And I dare say that public health is life-sustaining. Our colleagues are there to respond and engage immediately and to save lives. But for many of us in this work, what we're looking at is how can you actually have a quality of life after you've been saved? It's not good enough to stop the bleeding if I just leave you on the side of the road because now you're still alive. What else do you need now? Right? So this conversation of life-saving versus life-sustaining. And ultimately, as I said, our ultimate goal is to make sure that we have resilient communities so that we have resilient people and a level of health and wellness that we would expect in a nation such as ours. So I know that in this room, we've got a little bit of everybody everywhere and online as well at different levels, whether you're student, faculty, administration. You don't have to wait until you graduate and get your degree, whether that be an undergraduate degree or a graduate degree. And for those of you who are degreed, you don't have to wait for that next level of certification or that next degree or that next training. Use what you've got. Start where you are. Do what you can. Now. With that, I say thank you. I have input. I always share my LinkedIn. I'm always excited to hear from people and to know about what activities, initiatives you've got going on that relate to this level of work. So please feel free. If you go on LinkedIn and you just look up my name, you'll find me there. But again, thank you so much for the opportunity to dialogue, and I look forward to discussion and questions that might follow.
One more round of applause. So I will watch online, but we'll open it up to folks here first. Questions that folks have. I know sometimes people are shy, so I'm gonna.
I see one.
Oh, is there one? Oh, please go ahead.
Hi, my name is Dimitri. Might be a little far-fetched, but very beginning stages of developing a PhD project. And my SPOH, really looking at data capture and then more importantly for internet. This might be a little bit broad of a question, but you just seem like the kind of person that has.
Yeah, well, considering I also have a DMP, and we understand each other. So a couple of things. So the first thing would be for you to also consider what is the issue that you're identifying, right? Because the emergency room should not be that safety net, but there's a reason it is, right? And so when you look at that applied to social determinants of health, you'll also get a bit more of an understanding on how it is that the emergency room has become the place for whatever group of people that you're starting to see it, right? So by way of resources, I would definitely point you to CDC, as well as the Office of the Assistant Secretary for Health, because through Healthy People 2030, there's actually a whole section about social determinants and the metrics that the federal government is using, and also some recommendations based on if there's a particular area, one of the social determinants, or just collectively. So there's metrics that you can actually use and apply those at a community level or neighborhood level, depending on where you're going with that project. But those would be the primary two resources based off of the way you've described it, at least right now. You're welcome. Oh, and one last thing, the CDC Social Vulnerability Index. Social Vulnerability Index. So that one is really a good resource to really look and see what's going on in particular communities. And there's another one, I think through the through ASPR in HHS. It's called Empower. And what that does is it overlays folks in the community who are power dependent, electric dependent. And so you can also see some of those determinants as it relates to their health needs. You're welcome.
Hi, my name is Laura. I'm an assistant professor in the nursing department. Thank you so much for your talk. I'm curious if you have any suggestions about this community engagement piece versus this social isolation that we've all kind of been moving towards, especially at Temple. I feel like we're really trying to become more neighborly with the folks living in the community that this university is kind of situated within. And so is there any suggestions on strategies on how to rebuild some of those engagement movements?
Yeah, I think it's important to understand what people are gravitating towards in isolating themselves, right? There's a reason that people find comfort in that. And so outside of, and there might be still a continued fear related to COVID, but even absent that, I think, people have gotten comfortable in that space. And it's not until you understand what is actually driving them in that direction that you can even consider what you can put in place to move them in another. One of the conversations that we had, which was related, was, this push to return to the office, right? So in the federal government, that's a big conversation right now. And so when you change your thinking to, how can we make them come in, to how can we make it a desirable place that they want to be? Right? So in order to pull people out of their self-induced isolation, you'd have to give them a reason. Why is it better for me to come and engage with you? What's in it for me? And I say, we are building this, generation. We used to say it's the generation coming. Now it's the workforce. Again, what's in it for me is a valid question. And we have to be ready to answer that. And if we can't, the onus is on us to figure that out, as opposed to putting it on the person to make them change their behavior, and there's nothing in it for them.
Very wise.
Other questions? Please go ahead.
Hi, my name is Jay. I'm an assistant professor. I'm also a dentist. See that the world health really is important. When it also comes to the policy, the coverage for many preventative services are not covered. So even though we have some ample of evidence, but when we try to practice this at the care side, we fail. What are your recommendations?
Yeah, my sense on that is that dentistry has not had a seat at the table in talking about health. Similar to the conversation about behavioral health, right? People tend to speak about physical health and they forget, at least my mouth is connected to my body, right? And you know well that, oral disease will impact your whole system, And so dentistry has got to be a part of the conversations, right? So that when you're talking health, you are always including that impact and opportunity, because you're correct. Many times the policies are developed and written not with the intent of carving anyone out, but you don't know what you don't know. And if you're not at the table, then you can't share. But the onus is also on everyone else, because now at least all of you in this room have heard that dentistry wants to be a part. So if you've not included dentistry, now's the time to begin doing that, because there's probably an aspect, an element that dentistry can share with you that you probably had not considered. Because I can tell you, I didn't learn anything about dentistry, this much about oral health in my nursing preparation, and that's both as a family nurse practitioner and an RN. So I would welcome that conversation. And, to also piggyback, I mentioned the categories in our public health service, and we have a chief professional officer board, and we do just that. And so there are things that our chief dentists and chief pharmacists will bring to the table that I hadn't considered or didn't even know. And I would challenge you to be of service to others and for everyone else to look for dentistry in your conversations about health.
Thank you.
You're welcome.
I think we have time for one more, if folks have one more question. If not, I know we're at 1 o'clock and we can wrap one more.
Did you?
Okay, then we will wrap up. For the students who are here, we're gonna flip the slide for the QR code for anybody seeking points for the Suitable initiative. But again, thank you so much. I think you've given us a lot to think about. I know you have a packed afternoon heading up with our nursing colleagues. But again, please, let's thank Rear Admiral Diggs for being with us.